groundbreaking news that Dr. Kämpe wanted to share with the group. So he's going to speak for just a few minutes about the new developments in premature ovarian insufficiency. So thank you so much, Dr.
I didn't even know that was.
Thank you. I try to be very brief here. So you remember in Addison's disease we have these 21 hydroxylase antibodies. In autoimmune premature ovarian insufficiency, which can be part of APS1, there is another enzyme in the same synthesis system, side chain cleavage enzyme, that seems to be the major autoantigen. So we have a test for this, which is not as good as the 21 hydroxylase, but it's fairly good. And this enzyme is expressed both in the ovaries and in the adrenal. So we did a test, and now it's not in APS1 patients, it's in patients with isolated Addison's disease and premature ovarian failure. Since around 15% of females with isolated Addison's disease also gets this premature ovarian insufficiency. So what we did, we didn't use a sexy new treatment like Dr. Leonakis gives Rux or something. We used a much more conventional immunotherapy, rituximab. And the reason we chose that was that it was one of the few immunomodulatory agents that was shown to be fairly safe in a pregnancy. So we don't want these women to be pregnant during the study period, but of course we can't be sure if they will or not. So what we did was to do a standard ovarian hyperstimulation, and then looked whether there were any follicular development or development of eggs. And then they got 2 injections with 2 weeks apart of 1 gram of rituximab each time. We waited and did a new hyperstimulation and looked again. And then we wanted them to wait to try to get pregnant until 12 months have passed. So here are 7 patients with Addison's disease and premature ovarian failure and some other diseases. None of them had any follicular development or egg at the first hyperstimulation. But you can see at the second stimulation, we do get quite a good results. I would say astonishingly good results. And we have 2 with, we actually have made embryos for cryopreservation. One of them will be tried for IVF the coming month. So, none of them responded prior to treatment, but 5 or 7 got spontaneous menstrual bleedings, which they did not have before. And in 5 women, we have harvested eggs or have embryo preservation. So the question is, should in APS1 you aim for a very early oocyte or perhaps ovarian preservation? And will rituximab work? That's something we don't know. And should we also try with sperm cryopreservation? Because we know that some male patients have a subfertility problem. And I will just show you, for the males, they develop transglutaminase 4 antibodies, a good marker. And here you can see that it's expressed in the epithelium of the prostate. We just had a look at 6 of these patients where we had a lot of different. These are actually 6 Finnish patients, and we got all these samples from Jakob Pärentorp in Helsinki. So it's continuous. So the question was, when do the antibodies appear? And the antibodies appear, as you can see, around puberty. And that's when the transglutaminase 4 appears in the prostate. That means that there might be a window of opportunity both for the females and the males if you early on try and do cryopreservation. Then of course we can also later on try rituximab, but we don't know whether it will work or not. So these are the questions. So I finish here. Thank you.
I have 2 questions. Do I understand correctly that with the rituximab women who were already in premature ovarian failure resumed function?
Yes. And some after very many years. So apparently there is some sort of regeneration in the ovary that we don't see in adrenals, for example, or in beta cells.
And then do you anticipate that the rituximab will have long-lasting effects, or is it an effort to do the rituximab twice and then harvest eggs or do IVF shortly thereafter, or is it something that you would anticipate?
No, we don't think it has long-lasting effects. And when I say that they have had menstruations, in most cases that goes away after 1 or 2 or 3 cycles. So we do the treatment, we pick the eggs, and then the IVF.
And are you doing more research to answer more questions on this?
I think for those 2 questions we don't need to do that much research. It's an ethical question.
That's absolutely.
Yeah, but for what we do have to do research on it is to see whether we can modify using rituximab or something else.
Do you have a sense
In those EPS1 patients who already developed premature ovarian failure.
Do you have a sense yet of whether the length of failure impacts the treatment?
We have too few patients, but it's remarkable how long it can be between the diagnosis and this treatment in this very little sample. We are going to do a randomized control trial, so in a larger set of patients to test.
How soon do you see your gonadotropins dropping down after rituximab? Do they drop right away? LHFSH.
They do drop in. I have all the data.
Okay, I'll have a peek. My question is, it's not really a question, it's a comment, because in other contexts, we do send adolescents to our infertility, a large infertility clinic at Saint Justin. And you mentioned ethics. The problem is the window that you think you're going to have to do this in young men, they're pretty young. And getting sperm donation and getting a 14-year-old male totally aware of what they're doing and why they're doing it, and then being willing to give a donation, that's a pretty difficult road to navigate.
That's why it's...
Would you go to testicular
That's what
biopsies?
those 2 charts were about.
Yeah.
That's too early.
That's a possibility, of course. You use it for Klinefelter, but can't be that hard for a 14-year-old afterwards.
Give them a Playboy and tell them to work out. Ask all the moms and boys that.
Okay, if you're trying, like from a doctor's point of view, if you're trying like to decide to retrieve eggs or not, what is better, retrieving the eggs or just waiting?
Well, we do retrieve the eggs. We pick the eggs.
Yeah, but which one is, like, if you're trying to decide if you want to or not, which is better in a doctor's point of view? Is it, should I retrieve eggs or should I just?
I think the sooner the better, the higher chance, and then you can always decide whether you like to be pregnant or not. I mean, that's a later decision.
We have a question from Dr. Powell.
It's more of a comment
Okay.
akin to, I showed you those two charts about the brain development, the cognitive understanding and abstraction as well. So just, there are definitely ethical issues around this, and you should have psychology and other people involved, and there's evaluations.
Yeah, that's why we have question marks afterward.
I have a question. Are you excluding patients who have primary ovarian failure or
No, not at all.
none at all?
That's why I showed the development of the antibodies against transglutaminase 4 that I think illustrates that there might be a window of opportunity if you choose the right time.
Yeah.
Getting my screen there.
I'm not exactly sure how to say, but would this medication be typical or no? I assume it would not be typical, or at least not a typical use for most physicians working in fertility medicine. So I'm wondering how would you approach that topic with them, or how could you introduce them to that concept?
Well, we have to do a randomized controlled trial to see that, so far in these patients we have not had any issues with adverse reactions in any way. It's a very safe drug. And that's something we know from treatment in multiple sclerosis, rheumatoid arthritis, etc. And so of course now we are, I'm not doing the ovarian hyperstimulation myself. We're working intimately with gynecologists doing this.
Yeah, are you going to publish this data?
We hope to publish it soon. Yeah.
We put that Brendan, we have another question waiting over here. We're going to get you a mic.
Can I ask a question while we're waiting for a microphone? I just have a quick question. Are they going to do a male study, kind of a counterpart of the female, to see if a male who is infertile, if rituximab allows for a period of fertility?
It's nothing we have planned, but of course, that's really something that should be done. Yeah.
Brendan, go ahead.
Rituximab is a JAK inhibitor, is it not?
No,
No, it's not.
no, it's an antibody against CD20, so it affects B cells. No, it's not a JAK inhibitor. So we don't want something that it could potentially be teratogenic and cause malformation. That's why we chose rituximab.
Okay, I thought it was a JAK inhibitor, so my question was gonna be, do you think you would see the same results with rituximab as you would with rituximab?
Or even better perhaps, but then you have the problem, right? Then they would need to be on contraceptives, and how do you get the eggs then? Difficult question.
Thank you very much.
Thank you so much for adding that information. We really appreciate it. And again, this is all emerging data and important issues we need to keep talking about for our patients